Welcome to Healthy Minds. I'm Dr. Jeff Borenstein. Everyone is touched by psychiatric conditions, either themselves or a loved one. Do not suffer in silence. With help, there is hope. Today on Healthy Minds, I want to start by talking about anxiety in youth and really talk a little bit about the prevalence, how often it occurs, and what the symptoms are.
So like you said, a little anxiety is not only fine, it's actually good for you, right? It's our body's way of telling us, hey, you're in danger, or hey, you need to do something. And when we listen to that in healthy ways, we get out of danger and we prepare for the things that we need to prepare for. But for the kids that we're seeing, their anxiety is preventing them from doing day-to-day things that they need to be able to do.
But now neuroscience is catching up to find out that there is actually something profoundly different about the adolescent brain, not just in terms of its connections, but how it actually functions.
That's today on Healthy Minds. This program is brought to you in part by the American Psychiatric Association Foundation, the John and Polly Sparks Foundation, and the New York State Office of Mental Health. Welcome to Healthy Minds. I'm Dr. Jeff Borenstein. What should you do if your child is experiencing extreme anxiety or obsessive and compulsive behaviors? Today I speak with leading experts, Dr. Francis Lee and Dr. Avital Falk. Avital, Francis, thank you for joining me today. I want to start by talking about anxiety in youth and really talk a little bit about the prevalence, how often it occurs, and what the symptoms are.
Yeah, so anxiety is extremely prevalent in youth, and about 1 in every 4 or 5 kids, teens, adolescents are struggling with anxiety. And so we see it as a huge problem that we really want to address, and it comes on board early. So we want to intervene as early as possible to allow people to live the lives that they want to live and be able to function and do all the things that they want to do.
Tell me about the symptoms that people experience when this occurs.
So earlier on, it can look like separation anxiety, having trouble separating from a parent, having trouble going to school, sleepovers at friends' houses. But it can also look like other things. Anxiety comes in a number of forms, and there are a number of anxiety disorders. And what distinguishes them is really what the source of threat is, what somebody is afraid of. And so, like I said, it could be separation and a fear something bad will happen to me or to my parent when I'm away. It could be social anxiety, where you're terrified of judgment and evaluation from others, be that teachers, friends, other people in your life. It could be a specific phobia, a fear of dogs or heights or something like that. And so there's many different forms of anxiety, but what's common is that there's something that's terrifying to this person, and they'll do whatever they can to try and get rid of that anxiety and or avoid that threat.
We know that young brains are still developing through adolescence and early adulthood. I want to ask a little bit about how the brain developing relates to anxiety, both in terms of it occurring, and the good news is the treatment of anxiety.
I think was sort of new in the area of neuroscience is that we always thought that the brain developed during early childhood, but what's also clear is the brain goes through a dynamic reorganization during adolescence. And we think this is very important because in many ways it suggests 2 things. It suggests that the brain is incredibly plastic. If you think about what the tasks an 11-year-old has to do versus a task that an 18-year-old has to do, which is early and late adolescence, there's so many more responsibilities and tasks, and you could imagine that the brain has to adapt to those. And so that's the good news, that the brain is incredibly plastic. But as Avital has mentioned, it is also a period of time when most of these anxiety disorders emerge, this transition between childhood and adulthood. And this is where we think that this heightened plasticity also allows for heightened vulnerability to these disorders. And I just want to also clarify that during this period of time, we're all allowed to be a little afraid of dogs and a little bit afraid of taking a test. It's that sort of continued worry beyond, like when the dog goes away or when the test is over, that really is sort of the source of what we consider to be an anxiety disorder. And this is what seems to emerge during this period of time. And for a long time, we've known about this, and we've always thought of it as a very interesting epidemiological fact. But now neuroscience is catching up to find out that there is actually something profoundly different about the adolescent brain, not just in terms of its connections, but how it actually functions. And to summarize 5 years of work into 2 sentences, there's a region of the brain called the hippocampus, which we normally think of used for spatial localization and navigation, that actually turns out to be very important in terms of also regulating anxiety and other fear-related memories and moods.
So the concern is, with the brain changing so much, it can leave somebody vulnerable to developing anxiety or some other condition. The good news is, with the ability for the brain to change so much, treatment can be effective both in the short term and in the long term.
Exactly. It's almost as what they have found in this other area of brain research, which in vision, where there's a critical period. There's a critical period to correct sort of conditions of amblyopia or dysfunction in binocular vision. And by early adolescence, if you don't correct it, it will be very difficult to correct. And it's sort of the same logic that we now have in the way we think about the developing brain, that in essence, we have a window with which we can intervene where we could get probably the maximal effects. And so it really suggests, the neuroscience suggests that the policy decision should be to essentially treat early and treat as the symptoms emerge, because most likely these symptoms do not get better, they actually get worse. And that the sooner you get treatment, probably the better the ultimate outcomes would be.
So a little bit of anxiety is natural, normal, and fine, but when it begins to affect the person's functioning, then that person really should get help.
Exactly.
So tell me a little bit about the treatment. What do we do when someone comes to help, for help? What do we do?
So like you said, a little anxiety is not only fine, it's actually good for you, right? It's our body's way of telling us, hey, you're in danger, or hey, you need to do something. And when we listen to that in healthy ways, we get out of danger and we prepare for the things that we need to prepare for. But for the kids that we're seeing, their anxiety is preventing them from doing day-to-day things that they need to be able to do. So they might have trouble going to school, they might have trouble seeing friends or spending time with people. And so what we do is cognitive behavioral therapy, which combines some cognitive work where the person is learning how to shift their thoughts to the most realistic version to make sure that they're thinking about things to match the reality that they're in. And also we shift their behaviors, and the biggest piece of this is what we call exposure, and that's facing the things that are difficult for you. And so 2 things happen when you do that. 1 is that you may learn, hey, this wasn't as bad as I thought it was going to be. And 2, even if it was as bad, you learn how to deal with that. And that's the biggest thing that we're trying to teach kids and families, is how to face things that they need to be facing or want to be facing, and how to deal with the things that come up as they do that, which can improve their functioning and get them back to living their lives.
And this type of therapy actually affects the brain. And that's part of what the basic research is showing.
Yes, so the basic research shows that normally the dogma was that the prefrontal cortex is very much involved in training you to realize that this previously dangerous situation is no longer dangerous. But sort of what we have found is that the hippocampus is also very much involved in this sort of learning process of regulating one's fears and anxieties.
So going to the place that causes anxiety, whether, for instance, heights, helps to extinguish that response in the brain.
Because in addition to the prefrontal cortex, you also are using your hippocampus, which in adolescence is now sort of in a hyperplastic mode. And so that you can imagine in the future, and this is studies that are being done at Columbia, Anne-Marie Albano is using virtual reality, for example, to do these types of CBT with enhanced contextual exposures that hopefully will be stimulating the hippocampus in her young adults and adolescents.
I want to use that as a springboard to talking about the use of technology. And I know that one of the things that you've been collaborating and working on is the development of an app in which cognitive behavioral therapy approaches could be used using an app?
Sure. So we know that cognitive behavioral therapy is a great treatment for anxiety, but there's a lot of barriers in terms of accessing that treatment. And not everybody can find it. They may not know it exists, or they may not have the means, or there's also sometimes a lack of providers who are providing that exact type of care that you might need. And so what we hope to do with our app is to be able to provide CBT, cognitive behavioral therapy, to a wider number of people and give them really easy access to care so that they can do it right from their own homes. And like Francis was saying, we really value going out and doing things and practicing things in the environment that's scary, and the app allows you to do that. So the app provides a full course of treatment, which includes all the different elements of CBT and allows you to do that from anywhere, wherever you are, and in the most helpful setting.
Would the person also have other forms of treatment along with it?
They could. So we think about this as a way to supplement the existing treatments that we have. So somebody might use the app in tandem with the therapist that they're seeing, or they may be able to do a full course of treatment on their own if that is the best fit for them.
And for this age group of adolescents, it would be very hard for them to actually want to sit and go to an office every day. So in addition to access, it's also adherence to showing up every day. If you actually put the app on their smartphone, which they check every 30 seconds, then they will be much more prone to or willing to use it. And in many ways, this is sort of possibly the most natural format with which we might want to deliver treatments for this age group. It just turns out that this age group loves using smartphones.
The easy availability of that treatment helps the person to retrain their brain.
Exactly.
It's almost like having the ability to do exercise without going to the gym.
Exactly. Or having your mobile gym with you.
Exactly.
And that's particularly helpful for not just this age range, but this age range with anxiety. Avoidance is the hallmark of anxiety. They avoid the things that are difficult for them. And so sometimes coming to a therapist's office and talking about your anxiety and your deepest fears is the hardest thing to do, and maybe a symptom of the disease that they're dealing with. So being able to do that in a way that eases them in and can be available right at home can be extremely valuable.
There are a lot of apps around. How does somebody know if one that they come across is appropriate to use?
So there are many apps out there. And we actually went at the New York Presbyterian Youth Anxiety Center and we looked at all the apps. And ultimately we couldn't find one that was actually optimized for this group of adolescents and young adults. And because there are a lot that are a little clunky, but more importantly, most of them were not validated in clinical trials.
They weren't proven by research to work.
Exactly. And so what we did was we built our own, and we optimized it so that it would appeal to adolescents and young adults. The main problem with many of these apps is that after a couple sessions, most people drop it. Sort of the same way that if you're doing a fitness app, you probably will stop using it after a while. And I think that's what we've been more concerned about. You can build the most beautiful app on a smartphone with all the bells and whistles, but if after 3 sessions they don't use it. And this is something we're thinking about very critically, because ultimately other aspects of app development, in, for example, in fitness apps, have figured out how to do this. They've used things such as incentives, such as games or other types of badges to essentially incentivize you to use this. And this, I think, is going to be the next generation of what digital technology will be able to provide. Not only sort of to be able to transfer what was been done in a one-to-one session, but also to be able to implant other things such as incentives to increase the chances that someone will actually complete their CBT sessions.
In all of medicine, people adhering to the treatment plan, whether it be medication, talk therapy for a physical ailment, physical therapy, the adherence is an important issue. So developing an app that people will actually use and be comfortable with and therefore benefit from is extremely important.
I completely agree. I think this is sort of what the future promise and potential of these digital apps for CBT and other psychotherapies will be, because we all know what we should do, but we don't do this. And ultimately, it has been found that if you can provide these types of incentives, you will hopefully be able to have the patients complete their therapy, whether it be physical therapy or cognitive behavioral therapy, in a manner that is most efficacious. Yeah.
I want to shift gears a little bit and discuss obsessive-compulsive disorder, OCD.
So OCD used to be part of the anxiety disorders category, and now it's in its own separate category. And it is similar in certain ways, but has some different elements. So obsessions are thoughts, images, urges, things that come in over and over and over again and are very distressing. Compulsions are the things that we do, whether that's a mental ritual or an actual behavior, that helps us feel better and provides temporary relief for those fears and obsessions. And so what happens is somebody has obsessions, and that could be about any number of things. It's whatever is most disturbing to them. And then they start to do these compulsions that make them feel better in the short term, and it brings them relief. And they learn, hey, that worked really well. So it teaches them, oh, I should do this again and again and again. And then all of a sudden you realize, oh my gosh, I'm doing compulsions all the time. And those compulsions can become so debilitating because they can interfere with day-to-day tasks and activities. And so even though long term it's really hurting them and they have to do these compulsions over and over, because in the moment it feels so good.
It relieves the anxiety
That's
that
exactly right.
the thoughts have for them.
And that relief is so reinforcing and feels so good that it keeps this cycle going. And so the treatment for it is we really try to break that cycle. And just like with anxiety where we do exposure, with OCD we do a form of exposure. It's called exposure and response prevention. And so not only are you facing the thing or the obsession that's worrisome to you, you're also preventing the response or preventing the compulsion. So we have people face their fears without doing the compulsion and learn, hey, I can be okay.
And the basic science related to this, could you speak a little bit about that?
So again, this is another area of the brain that is next to the prefrontal cortex, or a part of prefrontal cortex called the orbital frontal cortex. And these are studies were done in the early 90s, but essentially it was able to show that this brain region is overactive with another brain region called the striatum. So there's a sort of a loop of cyclical loop of overactivation. And we've known that for a long time. And what's interesting is this is an example in psychiatry where we actually know the circuit that is involved. And it's been very difficult for us to move the needle. What's very interesting about obsessive-compulsive disorder is that since the early 90s, we have known about the circuit that's involved in this disorder. It involves a part of the prefrontal cortex called the orbital frontal cortex and another subcortical region called the striatum. And that there's overactivation in this loop between these two brain regions. And so this is an example in psychiatry where for 2 decades we've known, or more, we've known the circuit, and we've not been able to develop optimal treatments. The good news is that recently the FDA has approved a new treatment for obsessive-compulsive disorder utilizing magnetic beams into this prefrontal cortical region, and it involves something called transmagnetic stimulation, or TMS. And I think this is something that can be used optimally in addition with exposure and response prevention. So you can now have a scenario where you can combine therapy with something that actually will tap into the exact circuit.
So you basically 1 + 1 = 3 in terms of combining different forms of treatment to help somebody.
Exactly. And this is a form of, and the reason why I think this is a great breakthrough is because obsessive-compulsive disorder is one of the more severe of the anxiety disorders, in the sense that once these obsessions come into place, it's very difficult to treat these. And in many ways, trying to convince a patient to come in and be exposed to things that are most anxiety-provoking for them is very difficult. And I think that we've begun at the New York Presbyterian Youth Anxiety Center a very innovative programs to try to get around this, where in essence it's an intensive program that involves not waiting for the patient to come every week, but it was only begun recently, and maybe Avatar could actually speak to that.
Sure, go ahead.
So many of the children and adolescents that we see are really suffering, and they may not be able to go to school fully, or just day-to-day activities take them a really long time because they're so bogged down by how many compulsions they have to do. We've seen kids who have trouble writing, walking, speaking to people in just a regular manner. And so they need help, and they need help quickly. And so what our program does is it puts a lot of treatment in a short period of time so that they can get back to their lives very quickly and get better much more quickly. What we know is that this type of treatment works just as well as the traditional weekly treatment, but it can be done much more quickly. And so people get better in a short period of time.
Often people wait until they seek treatment. Parents may not realize that it's so severe for their child. The child may not say anything about it. People wait. For a parent who's watching right now, listening to us speak, who's concerned about their child, what should they do?
I would say come in. The scariest step is just coming in, but once you learn a little bit about it, how this works and how we treat it, it becomes much easier. And I think that the treatment, it may sound a little scary facing your fears, but at the same time, it is so empowering. So the kids that go through this, within just a couple sessions, which could be within 1 week because we're doing this in an intensive manner, they'll tell you that they feel stronger and better and more encouraged to do this. And they are our biggest advocates. They teach each other within our groups how to do this and how to face fears, and they feel really good and proud of themselves.
So they really begin to get relief right away.
Right away.
This isn't wait a few months for an effect.
We dive in within the first session or two, teaching people how to face the things that they'd like to.
This is so rare as compared to other aspects of psychiatry where we essentially tell them, we'll come back in 3 weeks, we'll see whether this medication has worked. And I think this is sort of an unsung success story of what we can do, that we've essentially taken evidence-based behavioral treatments and essentially just sort of supercharged them and found that they're just as effective in a shorter period of time, which is what every parent or every patient would want.
Right. Especially when a young person is suffering
Exactly.
to such a degree.
Exactly.
Let me ask you, what do you see down the road in the next 5 to 10 years in terms of our understanding of these conditions and the treatment?
So let me take a stab at that first. So I would say that 5 years from now, I see a scenario where someone would come in and be diagnosed with a disorder, hopefully with the first symptoms, so that within the first month or week of the symptoms, they would come in.
Instead of suffering for a long time quietly,
Exactly.
they come in right away.
Yes, because of the greater awareness of what these symptoms, while they might be mild first, can actually snowball very quickly. In the future, I see a situation where a patient will come into a clinic and they would see a clinician, but after seeing the clinician, they will actually get other tests, such as a neuroimaging scan, very similar to what you would do currently if you were seeing a neurologist. And then from the neuroimaging scan, a host of treatment options will be available based on the analysis of that scan. And while this sounds sort of fantastical, it actually is happening right now in clinical trials. But my great hope would be and wish is that when the adolescent comes in with an anxiety disorder, these types of sort of biomarkers will basically be able to tell the clinician whether or not they need to get a course of CBT or they need to go onto medications. And most importantly, this type of scan can be repeated because these are sort of magnetic resonance imaging scans, so, and they can be readily repeated. And you will also know whether or not the brain connectivity changes have occurred with the treatment.
So you could see the physical changes in the brain that result from the treatment.
Exactly. And you will also know that if enough brain changes have occurred so that you can actually stop treatment or taper treatment. At this point in our field, we actually don't know when to reliably slow down treatment except by symptomatic relief as reported by the patient. It would be wonderful to have another external sort of validating way to make decisions about when to stop or start treatments.
And this view of the future has really informed the way we've created this app. So we've done it in a modular fashion, meaning there are different sections. And so ideally, if we can figure out, oh, this person is struggling with these specific symptoms or these specific deficits, we can put this module first and say, this person might need more of this or less of this or doing things in this order. And we've created the app in a way that can be tailored to the individual and their specific presentation. So that if they come in and get that scan and we have an understanding of what they're going through, we can actually tailor the app directly to them.
So instead of a one-size-fits-all, it can be tailored to the specific needs of that individual.
Yeah.
Will make a big difference in people's lives so that they can get treatment right away that's effective right away.
So if a kid is struggling and needs help now, that's what our intensive program provides. It provides short-term care that gets them back to their lives very quickly.
Right. If the kid is missing school, it's one thing to miss a couple of weeks for school, it's another thing to miss a whole semester of school. And
we
if you
try
could
to get
avoid
them back
that,
within a couple of days.
Exactly. I want to thank both of you for the ongoing work that you're doing, both in terms of clinical work and research work. And I also want to thank you for joining me here today.
Thank you
Thank
for having
you.
us.
If your child is experiencing extreme anxiety that gets in the way of his or her functioning, don't let him or her suffer in silence. Get help. With help, there is hope. Do not suffer in silence. With help, there is hope. This program is brought to you in part by the American Psychiatric Association Foundation, the John and Polly Sparks Foundation, and the New York State Office of Mental Health. Remember, with help, there is hope. Until next time, I'm Dr. Jeff Borenstein.